Approach to Chorea. So in this talk, we are going to talk about the three important movement disorders with primary concentration on Chorea. What we call it as the ABCs of movement disorders, that is the Athetosis, Ballisim, and Chorea. The importance is these movements flow from each one to another. Many times they are interchangeably utilized based upon the situations and circumstances. And among all these things, Chorea forms the forefront which engulfs us into a major spectrum of disorders. So what is each one of them?
Hold both the hands straight like this.
So athetosis is slow, continuous, involuntary breathing movement that prevents maintenance of a stable position. What you can see is able to hold the hand, but when his outstretched hand is the slow breathing, involuntary movements is happening, and it's predominantly distal in nature. The type of underlying cause will give the etiology for this athetosis. Then we have people who have fast flinging proximal movements with large amplitude movements. These are called as ballistic movements. And then we have chorea. Chorea is an ongoing, random appearing sequence of one or more discrete involuntary movements or movement fragments. That is, so person is having one set of movement from one joint to another joint. There's something which starts, some small movements will happen which are involuntary in nature. Sometimes they appear like a semi-purpose. Someone is trying to move some of the arms in halfway through and they adjusted their movements. This is the type of movements what you see. So what you can see is most of these almost similar, especially when it to Chorea and Ballisim. The primary difference is the amplitude of the movements, what it comes down, and both of them are proximal movements, whereas athetosis is predominantly a distal movement. So where each one of them, how the terminologies changes in movement disorders. So as I told you, movements which are intermittent, irregular in shape, and based upon the amplitude, we call it as high amplitude chorea, we call it as Ballisim. Where there is a combination of movements, we call it as chorea and Ballisim. And then we have exclusive choreas. People similarly can have dystonias, which has sustained movements, and athetosis is unsustained flowing type of a movement. And there can be combination of each one of them together. So if you have a combination of chorea and dystonia, we call it as chorea dystonic movements, or dystonic athetoid posturing, or chorea athetosis, or when people may be having all the set of symptoms or combinations of various things happening at any given point of time, we call it a more potpourri type of a term called as dyskinesias, which is commonly used in levodopa-induced dyskinesias or tardive dyskinesias, where people tend to have mixture of various types of movements happening at any given point of time. So what is athetosis? Athetosis is slow, continuous, involuntary breathing movement that prevents maintenance of a stable position. It is almost previously athetosis used to be looked into a different set of movements disorders. Of late, athetosis has almost been amalgamated into dystonia, and hence you don't see the common utilization of the term athetosis movement commonly, and most of them are part of dystonic movements where it comes down. But as of interest on historical aspects, it was first coined in 1874 by Hammond, wherein athetosis in Greek, which means without a fixed position. Then Denny Brown spoke about that in telling that it involves primarily the hand, then the lips, jaw, tongue, foot, and finally in neck in decreasing frequency. It's akin to chorea, what he tried to describe as a chorea athetoid type of a movement. And it appears in a subject when they attempt to move some body part called body part associated movements is called as mid-beginning. Subsequently, athetoid cerebral palsy was common diagnosis, which included further 12 different types and up to 5 subcategories, which you could have seen in 70s and 80s. This is what was used to differentiate various types of so-called athetoid or athetoid cerebral palsies. Now, it has become almost akin to dystonic movements. From 1980s onwards, the pattern of users of athetosis started to change. When Salem and Adams, they described that it's a focal dystonia as special types of focal athetosis. Farn in 1999 told that when athetosis occurs in infants, should be considered as a type of dystonia. Then in 1989, a Lancet editorial suggested to consider the term dystonia in place of athetosis. So, in general, what we can tell that athetosis remains a useful term provided that it is used to refer to a distinctive distal dystonic movements with or without facial movements as originally described by Hammond and Shaw. Now, coming to the next set, that is the Ballisim and Chorea. So, both of them are almost similar and hence the whole talk would be primarily related to Chorea. As told, Chorea is derived from an ancient Greek word called as Chorea, or which means dance. If you look into it, the initial descriptions of Chorea dates back from Middle Ages. It coincided with epidemics of both infectious and psychogenic chorea, and affected individuals usually used to dance wildly in circles for hours and hours until they dropped from exhaustion. There used to be cults devoted to various saints because of these, what you call it as performances or ceremonial performances, what used to happen. Among them were Saint John and Saint Vitus. In 1418 at Strasbourg, Saint Vitus was called upon to intercede or to intervene and become a specific saint of this disease. The reason primarily was this chorea used to get cured if people touched the churches storing his relics. So hence the term Saint Vitus dance is also a historical name for chorea. Officially, first time, Philippus Aureolus Theophrastus Parcellus Bombastus von Wohennemin coined the term Chorea sancti vitae or Chorea lassavi chorea, and he gave it different varieties of names based upon the underlying cause for them. Thomas Sydenham, between 1684 and 89, George Huntington and Jean Martin, Michel Osler, Gower, they all discussed about various forms of chorea, and with that, almost chorea has become a prominent movement disorders down the time. So, how do you evaluate a chorea? How do you approach a person with chorea? The primary is, as I told you, family history, time course, phenomenology. Are there any exaggerating or relieving factors? What are the other associated neurological features, medical conditions, medications history, and neuroimaging and lab workup? If you have a systematic approach to this, you have almost been able to cover up the diagnosis of chorea. Normally, when we look into chorea can be broadly classified into childhood onset and adult onset. Childhood onset is chorea occurring below the age of 16 years, and adult onset is above the age of 16 years. Sydenham's chorea is a classical example of childhood onset, and Huntington's disease is probably could be an example of a classical adult onset choreas. Always remember, any patient with suspected chorea, these two disorders need to be kept in mind, and appropriate testing has to be done before any further extensive battery of workup is considered. So chorea, whether it is childhood onset or adult onset, we can broadly approach under following categories. One is they are sporadic, or it can be genetic forms. Sporadic in the form of autosomal dominant choreas, autosomal recessive choreas, X-linked choreas, or mitochondrial disorders. Now, I'll go to each one of them systematically so that we know what is involved in each one of them. So coming to sporadic chorea. So sporadic chorea, let us say an example-based approach. You see a childhood onset chorea has come to you on a background of probably throat infection, which is a streptococcal infection, where ASLO titers, you get a ASLO titers, anti-DNAs, and you do a cardiac echo, which is suggestive of a rheumatic heart disease. So when you get this, it's very easy. What you're seeing is Sydenham's chorea. And yes, treatment is very specific, which all of us know and can manage those things. This is some videos available on various forms of choric movements. It might also happen that you got a childhood chorea, you saw that, but when you worked up, you don't, the ASLO titers or a cardiac echo, there is no feature suggestive of a rheumatic heart disease. So what to do next? If it comes out negative, then the next step would be for a sporadic chorea to look into an imaging profile. Or adult onset sporadic chorea can come. I think in that case also, based upon the history, imaging would be the primary investigation of choice. And then when you get an investigation done, there are three probabilities when you get an MRI done. One, there may be structural changes. MRI can be normal, or there may be an abnormal mineralization pattern. So these things gives us what we are looking forward for. So if you look at structural changes, you can see these three different set of cases due to three different varieties of structural changes. One, chorea, what you can see related to cysticercosis lesions sitting in the subthalamic nucleus area. Second is the chorea ballism or hemichorea hemiballism, which is commonly seen in non-ketotic hyperglycemia. And the third is a chorea which is noticed following an acute infarct in the subthalamic bar globus pallidum region of the brain. Similarly, we can also have chorea due to infectious causes such as HIV, post-radiations, structural regions such as hemangioblastoma, people with brain iron calcifications, or with moya disorders. So different diseases, different etiologies can present as chorea as their core clinical features. So these are some of the examples for structural imaging findings to look into it when you think about chorea. So any of the structural changes can produce choric movements. It can be CNS lymphoma, non-ketotic hyperglycemia, metabolic disorders, bilateral steatopellidodentate calcifications, multiple sclerosis, various infectious causes, meningiomas, vascular malformations, and even trauma can cause or have a symptom of predominant chorea as their primary concern. So now we looked into chorea with a structural region. So when you have a structural regions on imaging, the first thing is to look into stroke, vascular event, tumors, malformations, and basal ganglia calcifications. Sometimes you may not get a specific structural lesions. You may just get basal ganglia necrosis. When you get this basal ganglia necrosis, we need to see whether this has occurred on a background of recent infection, or if there is a background of basal ganglia necrosis is there and there is a history of recent infection is there, then post-infectious striatal necrosis is the possible diagnosis. If there is no recent infection, but with basal ganglia necrosis, then you look at lactate and pyruvate levels. If they are increased, then you are looking into leak syndromes and other mitochondrial disorders. And if it is negative, you are looking into infantile bilateral striatal necrosis. If there is no necrosis, but only caudate atrophy is prominently noticed, then you will work up for inherited metabolic diseases, organic amino acids, lysosomal enzymes, skin biopsies, and then genetic workup as required based upon each one of those cases. Once you go away from structural lesions, you may happen to see that you have a patient and then MRI is normal. So what you can see in this lady, there is tremors on one side of the body, especially on the left side, you can see that tremors are there. And then you are having some orolingual dyskinetic movements, okay, or coriform movements. So you need to look into it. When there's a combination of both the things are simultaneously noticed, most common reasons would be drug-induced. That's what we need to keep in mind. So there are various medications which can present or have chorea as prominent features. Commonly among them, what we know is about levodopa. Many patients with levodopa-induced dyskinesias, when they come first time to the clinic, and if they don't divulge that they are on levodopa, most of the time it ends up that people have been considered to have Huntington disease. And then after someone else digs into the history, they found out that they're regularly taking levodopa, which they're popping in, and they decided not to tell to the doctor. In addition, there are various other forms of coriform movements are there, which can be drug-induced. Even anti-epileptics can produce choreiform movements, what can be noticed in various set of patients. Even the most common what we use for management of movement disorders, especially triacylphenidine. People have been treated with triacylphenidine, for example, for tremors, as in this case. Tremors are better, but patient now comes with complaint of orolingual dyskinetic movements or orolingual choric movements. You can see that this patient before and after the movements, those videos have gone, means the movements have gone. So keep in mind when you're treating people with triacylphenidine and a person you have been treating for a X symptom and then comes with a new onset of symptom, you need to keep those as a probability that whether it is a anticholinergic induced chorea. There are various medications which can cause chorea, including dopamine receptor blockers, anti-epileptics, psychostimulants, anti-Parkinsonian medications, calcium channel blockers, and various other medications, including steroids, oral contraceptives, to name a few. Sporadic chorea, as already discussed, with normal MRI can also be seen in various metabolic causes, such as renal diseases, infectious causes, or in the presence of a pregnancy, where we call it as chorea gravidarum. So now coming to a brief overview, when you look into sporadic chorea with normal MRI, most important is to look for medication or drug history. If there is an association is there. If it is a clear acute onset, means you've taken the medication, symptoms after, then it may be acute drug reaction, or people have been chronically exposed or exposed some time back, then to consider tardive syndromes. If there is no if there is no history of drug or medication possible cause of chorea is there, then you will go for metabolic screening. Usually in level 1 of investigation, you look into electrolytes, glucose. In ladies, look for pregnancy test and thyroid function testing. And yes, you may get a clear answer for that. If you don't get a clear answer, then you go to the level 2 of investigations, which includes APLA workup, looking for SLE workup, autoimmune workup, look for polycythemia vera, thrombocythemia, celiac disease, HIV, B12, syphilis, lead exposure, and paraneoplastic and infectious causes. Most of your patients, we end up getting an answer. If it is a treatable causes of chorea is there, you are able to get an answer there. Sometimes it may happen that you don't get any answer down here, then you need to work them up further. The most common point of entry for workup would be from a liver function test. If liver function tests are normal, then consider for working up for genetic causes, especially for ataxin, and you look for Friedreich's ataxia, ataxia with telangiectasias, or ataxia with oculomotor apraxias. Or if LFT is abnormal, look for CPK, and if CPK is normal, consider acquired hepatolenticular degenerations such as Wilson disease can be considered, or if the LFT is normal but CPK, LFT is abnormal and CPK is increased, then you need to work up for genetic workup to consider for that. So this is a flow chart how to approach to a sporadic chorea with normal MRI. Initially, you get a normal MRI, but then you go to a metabolic screening, and then how it flows down to, if all of them turns out to be negative, to look into genetic workups. So this gives you an understanding when what has to be investigated. So now coming into genetic choreas. So as I told in my initial slides, genetic choreas can be autosomal dominant, autosomal recessive, X-linked, or mitochondrial. So there are various adult onset and childhood onset coriform disorders are there, which are autosomal dominant, autosomal recessive, or X-linked or mitochondrial disorders or inborn errors of metabolism. So to name a few, I mean, it's difficult for me to cover up all these things in detail. Just to get a glimpse of them, Huntington disease is a classical choric disorder which has an autosomal dominant inheritance caused due to mutations in chromosome 4, which codes for Huntington protein. People will have CAG repeat expansions, and complete penetrance is usually indicated at more than 4 repeats, 40 repeats. Commonly seen between 30 to 40 years of age, but can manifest at any age. Common clinical features include chorea, Parkinsonism, behavioral issues, and cognitive disorders. It's standard that any patient's adult onset chorea, you always consider for a workup for Huntington disease once the metabolic causes or normally easily treatable causes are ruled out. Other causes of other than Huntington disease like presentations, people, when you get this Huntington disease testing done, it may be negative. Then we are looking at Huntington disease Phenocopies and non-Huntington disease Phenocopies. Huntington disease Phenocopies are those which have similar presentation like Huntington disease. That is, they have autosomal dominant penetrance and have clinical features similar to Huntington disease. These include C9orf72 mutations, SCAR17, Huntington disease like type 2, DRPLA, neuroferritinopathy, familial prion disease, CACNA1A, VPS13A, VCP mutations with HD phenocopies. And non-Huntington disease phenocopies includes primary familial brain calcification, ADCY5 related dyskinesias, benign hereditary chorea, and tuberous sclerosis. So C9orf72 is an autosomal dominant Huntington disease phenocopy commonly seen in Caucasians, which occurs due to a hexanucleotide repeat expansion of GGGGCC. Common age of onset is around 40 to 50 years, and clinical features include like sporadic ALS, FTD type of a presentation, behavioral and psychiatric symptoms, chorea, dystonia, myoclonus, tremors, and Parkinsonism. SCS17 is another HD phenocopy which has autosomal dominant penetrance with Caucasian and Asian population getting affected, and occurs due to CAG repeat expansion in chromosome 6. Chromosome 6. Common age is around 20 to 40 years. It has a dominant ataxia, chorea, tremors, Parkinsonism, along with pyramidal signs, cognitive decline, seizures, and psychiatric manifestations. Caudate cerebellar atrophy or putamen rim hyperintensities are noticed on imaging findings. Another disorder which has HD phenocopy is HDL2, which has autosomal dominant inheritance. African ancestry is the common reason, also noted in South American populations. Once again occurs due to CAG repeat expansion on chromosome 16 due to juxtaphilin 3, which codes for juxtaphilin 3. Clinical features are almost similar to Huntington disease, occurring between third to fourth decade of the life. Then the next HD phenocopy is DRPLA, that is dentatorubropellidoLeucian atrophy. Autosomal dominant pattern, predominantly seen in Japan, occurs due to CAG repeat expansion on chromosome 12, which codes for atrophin 1. Common clinical features include seizures, chorea, ataxia, myoclonus, dementia, psychiatric features, and sometimes almost similar to Huntington disease. MRI shows white matter lesions and cerebellar brainstem atrophy. Neuroferritinopathy is another disorder which has HD phenocopy. Similarly, it has autosomal dominant penetration, commonly seen in Cumbrian region of England due to chromosome 19, occurring due to light chain of ferritin gene, with common age of onset is around 40 years. The classical clinical features include chorea, dystonia, Parkinsonism, prominent oromandibular chorea, dysarthria, spasticity, cerebellar signs, and dementia are the known clinical features. Clinical diagnosis is based upon low serum ferritin levels, MRI showing iron accumulation or cystic changes in cortical or basal ganglia with pallidal necrosis. Sometimes even prion diseases, genetic prion diseases can present in the form of Huntington disease, as because they are all autosomal dominant. HDL1 is linked to chromosome 20, linked to PRNP gene. Common age of onset is around 20 to 40 years. It has similar clinical features to HD along with seizures and ataxic features. Spinocerebellar ataxias. Spinocerebellar ataxias can have presentations with chorea. The ataxia scars with chorea include scar 1, scar 2, scar 3, scar 7, scar 8, scar 12, and scar 48. Approximately 15% of subjects develop chorea in scar 1, and it's commonly seen in Cuban and Indian populations. Age of onset is around 20 to 40 years. Clinical features includes ataxia, chorea, dystonia, Parkinsonism, and MRI shows cerebellar or brainstem atrophy. Yes, imaging genetic testing would be clinching the diagnosis down here. Now coming to non-HD phenocopies. These are patients who have chorea but does not have classical presentation similar to HD, and hence they are called as non-HD phenocopies. These include bilateral striatopellidodentate calcification, ADCY5 related dyskinesias, benign hereditary chorea, or tuberous sclerosis. All of them tend to be autosomal dominant in penetration. Most of them, like calcium deposit in BSPDC, what you can see is calcium deposits in the brain. Then you can see related to the gene SLC20A2 gene, and people may have cognition, psychiatric, and other movement disorders. ADCY5 related dyskinesias is a familial childhood occurring symptoms. Usually people can have facial myoclonus, axial, hypotonic episodes of exaggeration of dyskinesias, and clinically they have chorea, dystonia, and myoclonus can be there. Benign hereditary chorea occurs due to mutations in TITF1 gene or NKX2-1 mutations, commonly seen in childhood, presenting with hypotonia, chorea, associated lung disorders or thyroid nodules diseases can be seen. They are increased for malignancies, so that's why they need to be screened for. Chorea in tuberous sclerosis is a rare feature, but can occur related to nodules in basal ganglia. Developmental problems, seizures, and behavioral symptoms are associated findings. Now, coming to autosomal recessive choreas. We covered up all the autosomal dominant choreas, which included Huntington disease phenocopies, and non-HD phenocopies. So autosomal recessive choreas include chorea acanthocytosis, Friedreich's ataxia, Wilson disease, aceruloplasminemia, HDL3, ataxia telangiectasia, AOS, spastic ataxia, xeroderma pigmentosa, PDE10 mutation, GPR88 mutation, hereditary epileptic dyskinetic encephalopathies, and various other disorders. So what are these? So Chorea acanthocytosis occurs due to mutations in chromosome 9 coding for VPS13A, which codes for the protein chorin. Age of onset is commonly between 20 to 40 years. People will have behavioral changes, psychiatric manifestations, and dementia. Chorea, dystonia, orolingual dyskinesias, Parkinsonism, and tics are the common associated symptoms. Patients can also have seizures and peripheral neuropathy. You can see in these videos significant injuries to the hand occurring due to severe chorea affecting the mouth where person is trying to protect his tongue bite and swallowing problems. Then are our X-linked chorea disorders. X-linked chorea disorders include Mcleod syndrome, Pelizaeus-Merzbacher's disease, Lubax or DYT3. Mcleod syndrome is an X-linked autosomal recessive chorea where present as similar to chorea acanthocytosis due to occurs the lack of XK antigen. Patients can have chorea, areflexia, axonopathy, cardiomyopathy, arrhythmias, elevated LFT bar CPK levels, seizures, and commonly seen in the male gender around 40 to 60 years. In Pelizaeus-Merzbacher's disease, leukodystrophy is noticed due to PLP1 gene mutations due to central hypomyelination. Patients will have pendular nystagmus, head tremors, generalized hypotonia, mental retardation, along with chorea athetosis, ataxic symptoms, and pyramidal features. In DYT3 or Lubax, it's common to the island of Panay or Lubac, and they have predominant dystonic posturing along with choric movements can be seen, which are X-linked disorders. Now, coming to inborn errors of metabolism. We finished autosomal dominant choreas, autosomal recessive choreas, X-linked choreas, and now we are coming into inborn errors of metabolism. Inborn errors of metabolism are common cause of hyperkinetic movement disorders, especially in children. And chorea is characteristic in glutaric aciduria type 1, glucose transporter type 1 deficiency, that is gluton deficiency, Lesch-Nyhan disorders, or Niemann-Pick type C disorders, which is adult onset. Associated features could be present in infancy but early childhood. There can be having presentations of encephalopathy, developmental delay, central or peripheral hypotonia. Patients can be having autonomic dysfunctions and seizures. So based upon those things, you need to make a decision what workup you need to consider for them. The other disorders are mitochondrial cytopathies. These are clinically and genetically heterogeneous group of diseases due to dysfunction in mitochondrial respiratory chain. They can present at any age with highly variable clinical course. Seizures, encephalopathy, stroke-like episodes, migraine, dementia, spasticity, peripheral neuropathy, chorea are associated findings along with these things. When you have a combination of those things, look into mitochondrial cytopathies. Chorea is commonly noted in the following mutations, that is Paul G mutation, MTTG, TND2, HSD10, M1CU1, COX20. And Chorea's predominant symptom in following mitochondrial cytopathies, that is leak syndrome, pyruvate carboxylase deficiencies, pyruvate dehydrogenase complex deficiencies. So keep those things in mind when you are deciding to get a final diagnosis for the disorder. Then lastly, coming to mineralization disorders. These are sporadic chorea which can present with brain showing abnormal mineralization pattern. Based upon abnormal mineralization pattern, different disorders can be considered, such as aceruloplasminemia, MPAN, PANC or PANC, BPAN, and PLAN. So what are these? So these are all related to neuroferritino, iron deposition or neuroferritinopathies, what we call it as. And commonly when you see mineralization pattern, first thing is to look for a PANC mutation. If PANC mutation is positive, you are looking at PANC mutation, or if it is negative, then you look for serum ceruloplasmin levels. If serum ceruloplasmin is significantly low and reduced, you are looking at aceruloplasminemia. And if it is normal, you're looking for the PLAT2G6 mutations. If it is positive, it's a phospholipase-associated neurodegeneration. And if it is negative, then you'll do further workup or genetic workup for FON, BPAN, or MPAN. This gives just a bird's eye view for how to approach for this iron deposition disorders. So generally, by knowing all these things, how can we approach? It's a complex, as you can see that there are various presentations of chorea and various causes for chorea. Based upon whether it is autosomal dominant, recessive, suspected, mitochondrial, or X-linked disorders, your approach significantly varies. If it is autosomal dominant, is it Huntington disease? If it is not Huntington disease, it is a HD phenocopy. If it is HD phenocopy, is there a brain calcification? Is there a brain iron mineralization pattern is there? Or low ferritin levels are there? Or is patient is from African descent, or there is predominant ataxic or cerebellar component are there, or there is associated Parkinsonism, myoclonus, or there's developmental issues are there, or any other malignancies are there, and then associated facial myoclonus. All these symptoms gives you for different types of diagnosis, which includes BSPDC, neuroferritinopathy, HDL2, familial prions, scar disorders, to name a few. This chaotic flowchart explains the complexities for approach with choreas. This is for autosomal dominant choreas, and similarly for autosomal recessive choreas, we are looking for any associated peripheral neuropathies are there, chronic foot changes are there, ataxia is there, oculomotor apraxia is there. Is there any epileptic dyskinetic encephalopathies are present? Are they hypersensitive to UV, ultraviolet radiations? Patients, which territory they are coming from? Are there any diurnal fluctuations are there? Is there any pyramidal associated signs are there? These will give a possible cues for what type of autosomal recessive choreas we are looking for, such as SPG58 in consideration for spastic gait, or if you are from Saudi Arabian descent, possibly you are looking at HDL3, or for example, if you're having ataxia, areflexia, chorea with foot deformities, diabetes, neuropathy, cerebral atrophy, can consider Friedreich's ataxia as also as a presentation. Thus, this is a glimpse to understand to those things. Similarly, as I told about autosomal dominant and autosomal recessive, in other genetics such as X-linked, inborn errors of metabolism, and mitochondrial disorders, the approach has to be maintained so that you systematically make a diagnosis for a person with chorea. Before I conclude down here, so how to approach to a patient with chorea? So patient with chorea requires seven critical steps. There's a nice video by Professor Cardoso, which all of you can reach it out on movement disorders in clinical practice to understand approach to chorea. So step one is to identify for non-neurological features. Are there any bruises or injuries? Then consider like neuroacanthocytosis, short stature, benign hereditary choreas, low weight, typical of Huntington disease, can be kept in mind. Then look for, is there any associated cognitive and behavioral issues? Significant cognition, behavioral affection is there. Huntington disease can be considered. Are there any ocular motor abnormalities, such as look for saccades, pursuits, oculocephalic movements? Then where is the chorea located? How common it is, how prominent it is. That gives an idea what you're looking. Is it only facial chorea? Is there only a focal limb chorea? Is there? Is it generalized chorea? What has happened to chorea over a period of time? Associated muscle tone. In degenerative disorders, it may be increased or it is reduced in acquired, like, which you call it as when people someday are not able to move, we call it as chorea paralytica. Then we can have look into gait and balance. How is there? Is there any ataxic features are there, or is there any spastic signs are there? Then other movement disorders. What is there dystonia? Is there something else? Parkinsonism is there? So if you look into all these things more systematically, probably the ability to narrow down your differential diagnosis, narrow down your workup, and to get a right answer with the least minimum investigations would be possible when you're looking for a patient with a chorea. So to conclude, what I can tell is athetosis, the ABCs, the athetosis, Ballisim, chorea are the common hyperkinetic disorders. Athetosis more commonly being replaced with dystonia now. Ballisim, chorea has varied causes. Systematic approach is required to narrow down to the diagnosis. Thank you. Thanks a lot. We do hope that this broad overview of approach to chorea along with Ballisim and athetosis gives an insight to the vast variety of clinical etiologies, associated symptoms with chorea. And any comments are there, please feel free to comment, or any specific highlights has to be done, please let us know. We'll try to cover it up during the subsequent sessions. Thank you. Thanks a lot.